Bismillahirrahmanirrahim. Welcome to this part 3 of a series of lectures regarding autosclerosis. Today we will talk about the management of autosclerosis. Now this is the nutshell of the management that there is medical treatment, then amplification, because mainly the complaint of the patient or the problem of the patient is hearing loss along with tinnitus. So hearing aid is best modality, and actual treatment is surgery, or there can be a combination of these. So this is the nutshell which we will talk about today in detail. As far as this medical treatment is concerned, the purpose of sodium fluoride is that it tries to herald the disease process, and the disease which is at active stage, it tries to convert it into inactive phase. So you can very well imagine the indication for sodium fluoride use is only in those 10% of the patients who are at the time of presentation in active phase, which we label as autospongiosis. Otherwise, in established cases of autosclerosis, which are more than 90% of the patients, sodium fluoride has got no role. So, its aim is to stabilize the disease by reduction of the osteoclastic bone resorption, because this fluorapatite complex, it stabilizes and it increases the osteoblastic bone formation, and it inhibits proteolytic enzymes that are cytotoxic to cochlea. So cochlear damage is also avoided by the use of this sodium fluoride. So it slows the progression of this sensory neural hearing loss. Not commonly used. Its dose is 50 to 75 milligram per day for 3 months to 2 years, depending upon the active phase of the disease. So autospongiosis, as I told you, there we use it, or if the patient is having cochlear autosclerosis, then we can think about the use of this sodium fluoride therapy, because it has got side effects like fracture of long bones and of the spine due to fluorosis, and it also causes nephritis and gastritis. Contraindications in patients with chronic nephritis are renal stones, chronic rheumatoid arthritis, pregnant and lactating women. In children, we cannot use sodium fluoride. Then as an alternate, we can think about bisphosphonates, which includes alendronate, risdronate, zolidronate. So these are the compounds which induce osteoclast apoptosis, therefore inhibiting the bone resorption. Hearing aid is very effective in early stage of the disease, but in advanced stage also there are specific indications for hearing aid use. For example, if surgery is contraindicated in some patient, or patient refuses the surgery, or even in combination with the surgery in far advanced cases, it is required even after stepidectomy. As far as surgical management is concerned, poorer ear is always chosen for surgery. It is done preferably under local anesthesia so that the patient can notify to the surgeon if vertigo occurs during procedure. The surgical options are stepidectomy and stepidectomy. As the name indicates, stepidectomy means removal of the footplate of the stapes, while stepidectomy means making a small hole in the footplate of the stapes, which is not removed, and a prosthesis is being placed. So you can say that stepidectomy is a conservative procedure, and nowadays this is an era of conservative surgeries. So nowadays we go in favor of stepidectomy. Otherwise, stepidectomy can also be considered. Then keeping in mind the complications of the surgeries. Fish reversal steps stepidectomy is also being tried, or stepidectomy minus prosthesis, that is stamp, is also being tried, so that all those complications which are related with prosthesis, for example, not proper size of prosthesis, or dislocation of prosthesis, or rejection of the prosthesis by the body, that can be avoided. Previously, mobilization of the foot plate of the stapes and Lampert's fenestration operation was used, but due to their failure, in the sense that recurrence of the disease was frequent, these have been obliterated now. In Lampert's fenestration operation, that foot plate of the stapes was removed from oval window and it used to be placed on another area, making a hole there and connecting it with the perilymph, but it was not that much useful. So these are being obliterated now. Lesser complications are nowadays due to laser use, that instead of using micro drill to make a hole in the foot plate, the laser is being used, so less damage to the inner ear and less damage to the surrounding structures with lasers. So patient selection is very important. That result of tuning fork tests and audiometry, skill of the surgeon. Surgeon should be well versed with the surgery. Facilities available in that particular center. Medical condition of the patient. He should not be having any debilitating disease. And patient's wish also. He is willing for surgery or not. Advantages and disadvantages should be discussed with the patient in detail with repeat clinical visit. So hearing threshold should be there 30 decibel or worse. AB gap at least 15 decibel. Rhenes should be negative. Speech discrimination score should be 60% or better in mixed hearing loss, and in far advanced diseases severe to profound hearing loss even in 90 to 100% 100 decibel range. Best surgical candidate is the one who is previously not operated, in good health. AB gap is unacceptable, that is 25 to 40 decibel bilaterally, and Rene test, of course, it is negative, showing the conductive type of hearing loss. Speech discrimination is good, and patient is willing for surgery. Age of the patient should be considered, because elderly patients, they poorer results in the high frequencies, because already they are having presbyacusis. Then in congenital stapes fixation, success rate is only 44%, but in juvenile otosclerosis, 82% is the success rate. Then those patients whose job is where there is too much fluctuation in atmospheric air pressure, like those who are swimmers or divers, pilots and airline stewards and stewardess, because in the aeroplane there is too much change in atmospheric pressure, and so that leads to problem with the eustachial tube dysfunction. If patient is having Meniere's disease with vestibular symptoms, or some other otological disease like cholesteatoma is there, or tympanic membrane perforation is there, so those are poor candidates for such surgeries. The prosthesis which is being used, that is made up of Teflon or stainless steel. Platinum Teflon piston is also available, and titanium Teflon pistons are also available. In total stepidectomy, when there is extensive fixation of the foot plate or there is floating foot plate, then we have to go for stepidectomy, in which whole foot plate of the stapes is removed and a graft is placed there, especially the cartilage graft, and then a small hole is made in that graft through which the prosthesis is transmitting the sound to the inner ear fluid, and on the side it is connected with the incus. But disadvantages with the total stapidectomy, as you can very well imagine, increased postoperative vestibular symptoms. It is more technically difficult, and there is increased potential for prosthesis migration or dislocation of the prosthesis or displacement of the prosthesis. So Stepidectomy, as the name indicates, that foot plate of stapes remains there. Of course, if it is not floating type, it should be fixed there. So a small fenestration is being made, or small hole is being made with micro drill or with the laser in that fixed foot plate of the stapes, and through which the prosthesis is being fixed, and the other side is fixed with the incas, and the sound is being transmitted. First laser stepidectomy was performed by Perkins in 1978. So less trauma to the vestibule, less incidence of prosthesis migration, and less fixation of the prosthesis by scar tissue. So in this picture you can see that this is the incus, this is stapes foot plate, and stapedial tendon is being cut with the laser. Then this small hole is being made in the foot plate of the stapes, and this is the prosthesis which is being fixed here in that hole which is being made in the foot plate of the stapes, and the other end through that ring type it is being fixed with the incus and clamped there. And this is the tympanomeatal flap to start with. Through the external auditory canal we make an incision along 7 o'clock and 12 o'clock, and then we take the tympanomeatal skin along with the tympanic membrane is reflected, and we are directly into the middle ear. And once the procedure is completed, that tympanomeatal flap is being replaced again. Of course, this is being done under microscope. So anesthesia, local anesthesia, then incision at lateral process of the medius and inferiorly, tympanomeatal flap is elevated. After adequate exposure, facial nerve is superiorly, pyramidal process is inferiorly. Distance from the incus to foot plate of the stapes is measured. Usually it is 4.5 millimeter. Micro drill is used to create the fenestra, or if laser is available, laser can be used, as I showed you in the picture. There the laser was used to make the fenestra, and then prosthesis is placed on the incus and crimped firmly in place, and other side is there in that fenestra. Incostapedial joint is separated and stapedial tendon sectioned. Stapes suprastructure fractured and removed, and prosthesis is checked for its mobility, and tympanomeatal flap is returned to normal position. This is what we call as small fenestra stepidectomy. So stepidectomy, it is safe, low rate of high frequency sensory neural hearing loss postoperatively, while in stepidectomy there are less chances of recurrence. Patient's head is elevated to 30 degrees to reduce the perilymph pressure in the vestibule postoperatively. Bed rest for at least 1 hour. If no vertigo and getting up, then patient can go home. Patients can resume air travel after 5 days and follow up with the audiogram in 3 weeks. Contraindications for these surgeries are that only hearing air, or Meniere's disease, or occupation where there is frequent change in pressure, like pilots, like air hostesses, or divers, those who work in noisy environment. Then if there is external ear or middle ear infections or perforated tympanic membrane, then young children in which there is justitial tube dysfunction leading to otitis media with effusion frequently, or old age patients in which there is already high frequency sensory neural hearing loss, so the results are not that much good. Poor state of health and especially during pregnancy. These are the contraindications. Complications, in 0.01% of the cases there can be sensory neural hearing loss. Vertigo, it may be transient and brief, or it may persist for short time, or it may be even permanent. Then facial nerve is at risk in any middle ear surgery, so same is the case here. There can be tinnitus postoperatively. Auriculotemporal nerve is cut, so taste disturbance will be there. Perilymph fistula can be there as a complication of surgery. In 1% of the cases, total dead ear can result, and iatrogenic tympanic membrane perforation. So with that we come to end. If you like and you think it is beneficial for you, so share it with your friends and subscribe the channels for future notifications. If any queries, most welcome in the comments section. Thank you very much.